This vascular territory is, of course, the anterior cerebral artery territory hugging the midline. This territory out here, you can see the area of normal brain is the MCA territory. The finding on this scan is the loss of the insular ribbon and loss of the border of the lentiform nucleus on the left side. So if you notice on the patient's right side, you see the internal capsule sharply, well, relatively sharply defined lateral border of the lentiform nucleus and the relatively higher attenuation insular ribbon compared with the white matter in this location. If you contrast it with this side, you can see a portion of the insular ribbon and then no insular ribbon. So this kind of bland appearance here, going from the internal capsule all the way to the Sylvian fissure, is abnormal. When you compare it to this side, where as you go from this internal capsule to the Sylvian fissure, you have the lentiform nucleus and a little bright tissue here, the cortical tissue along the insula. So the implication here is this patient has a left-sided infarct, and the symptom would be, of course, in most patients, aphasia. In this patient, I'm only giving you a single slice. You might be suspicious that this is a dense middle cerebral artery on the right side compared to the left side. Again, you'll notice here on the left side, the head of the caudate, the lentiform nucleus, the insular ribbon. On this side, you can see loss of the lentiform nucleus. So look at the difference between the basal ganglia, left and right, and this finding in conjunction with this finding would support that the patient has a large vessel occlusion. Now, in terms of a distinction between a MCA occlusion and a internal carotid artery inclusion, I actually didn't give you an MCA choice on the right side, but what I want you to recognize is the head of the caudate is better seen on the left side than on the right side. So when you have involvement of the head of the caudate and the lentiform nucleus, you have to be suspicious that this is actually a distal ICA occlusion and an MCA occlusion rather than just an MCA occlusion. This, of course, is an aneurysm because it has about the same attenuation as the parent vessel, as opposed to this and this, which are vascular loops, and DSA does allow that distinction. In this one, you can see that the jugular vein is much of higher attenuation than the jugular on the other side. They're usually roughly symmetric. And again, we're late enough in the acquisition that we do have some venous filling, but this marked asymmetry of the veins is unusual. And as I actually showed you this case, this is a finding that you can see sometimes with left-sided injections, which is why you should prefer right-sided injections for CTA. This one, I gave you a choice of embolic disease, and if you want to call it embolic disease, I'd like to see some emboli on the other side. This is right between the anterior cerebral territory and the middle cerebral artery territory, and I think this would be a typical watershed, white matter watershed distribution of infarcts. This one, kind of an odd, maybe not in the stroke realm, but I just want you to emphasize that when you see dilated vasculature, no intervening brain, this is typical for a cavernoma. And again, why cavernomas lend themselves to resection, because there is no brain inside of the hemosiderant ring, and so allowing you to resect the cavernoma itself. This one, here you can see the catheter in the common carotid. I know you don't all do in DSA, but I just make you familiar with the imaging. So here's the catheter in the common carotid artery. These are, of course, the external branches. The internal carotid artery is seen here. Usually atherosclerotic disease involves the proximal portion of the vessel. Here you see distally in the ICA, this rapid tapering, so-called rat tail appearance to the ICA. And this is a typical appearance of an internal carotid artery dissection with occlusion. The point I want to make in this patient is in a young patient with a lobar hemorrhage. with no sort of history that would help you. And we assume that the CTA showed no venous occlusion either, because vein of Labbé occlusions can present as lateral temporal lobe hemorrhages. But if the CTA is negative, you really should go on to DSA, because small arteriovenous malformations may not be visible on the CTA, because CTA is not sensitive to the timing of venous opacification. So this patient actually turned out to have an arteriovenous malformation. Again, something to keep in mind as you work up these patients with intraparenchymal hemorrhage. And this last case, making the point that this patient actually has a subdural in this location. I showed you that in one of my talks, but it looks like it blends in with the skull because the blood and the bone fall into the same range outside of the selected window. A lot of times for CT demonstration, we use a window of about 80, but you want to look at it again at a window of about 200 to be able to pick out these small subdurals along the skull. So in this last part of our time together, I want to go over infarct evolution. Let's see here. And so, sorry. In terms of timing of infarcts on CT imaging, I'm sure you're well aware that the initial CT scan can be normal, even in patients who have large vessel occlusion, depending on the timing of the scan and their collateral flow. But the important concepts we need to keep in mind when we think about infarct evolution is the presence of cytotoxic edema. Cytotoxic edema is, of course, what allows us to see the infarct on diffusion-weighted imaging. The concept is that with the injury to the cell membrane due to reduced blood flow, that there's an influx of extracellular water into the cells. So this is intracellular water and change in the diffusion properties of the brain in that location. This leads then to swelling, usually in the first week, and occasionally to hemorrhage, which may be, risk can be modified, of course, by the use of thrombolytic agents and underlying anticoagulation and size of the infarct. Eventually, the patient goes on, the edema and swelling will resolve and will be left with an area of encephalomalacia. So the late manifestation of infarcts, you can see ex vacuo dilatation of the ventricles and areas of low attenuation in the cortex as a result of the infarct. And well, I'm going to touch on this term. Not everyone likes this, but I think it's reasonable to talk about malignant infarcts. These are infarcts that the edema is so substantial that it leads to elevated intracranial pressures and can lead to brain herniation and death. So in the acute phase, in this patient with left facial weakness, there's really not much to see here. This is the initial scan. You could argue that the border of the lentiform nucleus on this side is different than the border on this side. And with history of left facial weakness, it would suggest a right-sided abnormality. The insular ribbon is normal in this slice. This is day 3, so a little time has gone by. Now we can better see the borders of the infarct here in the cortex and here in the deeper tissues and temporal lobe. So as you can see, there's a change in the appearance of the scan as time goes on. We also have a little bit of mass effect already here at day 3 with some effacement probably of the atria of the lateral ventricle. Here we are at day 5. The infarct is better defined, more of a wedge-shaped cortex and white matter involvement that touches on, as you can see, the lateral border of the basal ganglia here in this MCA territory infarction. So the infarct is progressing as you would expect. This one with not a lot of mass effect, although you can see the Sylvian fissure looks different on the right side and the left side. There is some swelling. At this point, we're dealing mostly with cytotoxic edema. Now, I want to touch on that, the terminology about edema. They talk about cytotoxic edema, vasogenic edema, interstitial edema, and so on. There are at least 5 types of edema. The one we think about most often is what we see with patients with, say, metastatic disease to the brain, where you see a large border of low attenuation around the metastasis itself. That is vasogenic edema. That is extracellular water that is due to a breakdown in the blood-brain barrier as a result of either a primary brain tumor or malignant tumor, a metastatic malignant tumor. The fact is that what you're seeing is water leaking through the loss of the tight junctions from the either absent or interrupted blood-brain barrier. So vasogenic edema tends to respond to treatment in case of tumors, sometimes Avastin. In case of metastatic disease, oftentimes responds to steroids, stabilizing those the vascular blood-brain barrier. However, in the case of infarcts, because it is cytotoxic edema, that is intracellular water, it tends not to respond to treatment with steroids. And so, in a sense, we don't have a good medical management for the mass effect associated with an acute infarct. Here we see now day 11. Now you'll notice the infarct was better seen on day 5 than it is on day 11. And now it looks like we have cortex out here. So what happened? Is this due to some miraculous treatment or stroke modifying therapy that was instituted? No, this is a phenomenon called fogging. And fogging is either due to some petechial hemorrhage or some change in the capillary flow with revascularization, or what they call misery perfusion. But in a sense, this is not the correct definition of the infarct. And so somewhere around day 10 to day 14, the infarct looks like it goes away or becomes less evident. This is not in all patients, but in some patients, this can be quite striking. And then after another week has gone by, all of a sudden the infarct is well seen as a very sharply defined area of ischemia. So again, be aware of this concept of fogging. This is due to, if you think about something of high attenuation into the infarcted cortex, making the infarct less visible when we get to that point of about 10 days to 2 weeks. This case that I showed you actually in the quiz here, just showing you an acute infarct, dense MCA, blurring of the basal ganglia. Here's that same patient 2 days later. Now you can see the low attenuation in the lentiform nucleus and the low attenuation in the caudate head in this patient with a distal ICA occlusion. Contrast that with the caudate head on the other side. Remember that the inferior caudate head is not supplied in most patients by the middle cerebral artery. It's supplied by a branch off of the anterior cerebral artery, the recurrent artery of Hübner. So when the inferior caudate is involved, as well as the lentiform nucleus, think about ICA occlusion rather than just an MCA occlusion. Here's a patient with a proximal ICA occlusion. Notice that we have blurring of the Sylvian fissure, where this is now, we're probably 3 days out, and you can see the infarct well defined. It's sort of wedged through here, involves the lentiform nucleus with sparing of the caudate head. This is an MCA infarct, as you might see it. This is a full territory MCA occlusion involving the basal ganglia. This is due to the lenticulostriate branches that arise from the M1 segment, sparing of the caudate head. Here's a patient that we see in the acute phase. And then 2 weeks later, we see some encephalomalacic change, but now we see this high attenuation, sort of as if someone drew it into the cortex. Is this hemorrhage? And if you call it hemorrhage, does that imply that your neurology colleagues should be worried about anticoagulation or antiplatelet treatment? This is thought to be is usually called petechial hemorrhage, or some material that is deposited in the cortex. This could appear on MR scan quite early in the course. Some places call this laminar necrosis, but in a sense, this is not the same as a true hemorrhage, which looks more like this. These are hemorrhagic infarctions. These are consolidated areas of high attenuation from blood products, not kind of a fine increase in either attenuation or T1 shortening in a linear fashion in the cortex. These are different entities and have different clinical implications. And then there's another concept. This is hemorrhagic transformation of an infarct. Here we see on this time point, this is early on. And so here you can see maybe a little blurring of the basal ganglia, loss of the insular ribbon, loss of the gray-white junction, right? So this is a left-sided MCA territory infarction. And then somewhat later, now you see that there's actually been a hemorrhage into the infarction. So this hemorrhage, this is a transformation of a bland infarct to a hemorrhagic infarction. So again, this is the concepts and things you should be looking for on the CT, follow-up CT scans in patients, particularly when there's an acute decline in neurologic status in the post-infarct phase. Now, this terminal malignant infarct, these are a large territory infarctions, usually a full MCA or MCA-ACA territory infarcts that can lead to mortality because of substantial mass effect, compression of the ventricle, and midline shift. As I mentioned, medical management of these large infarcts is difficult due to the intracellular nature of the edema. And so the treatment usually for these large territory infarcts is a craniectomy. And you can't really wait until there's a striking midline shift. It may be too late at that point. So a decision has to be made about the sort of quality of life issues and preferences of the patient or family in terms of survival. But craniectomy is often used in patients with these large territory infarcts to prevent fatal herniation from the uncontrollable swelling of the infarct. And then this is later we see, later we see the encephalomalacic changes. This was an ICA occlusion, again, caudate head, lentiform nucleus, MCA territory. There's some sparing of the MCA territory. This may have been an intervention in here. And now you see that there is this relaxed border of the brain as the swelling has gone down, and eventually the flap will be replaced here after the craniectomy at this point in time. Now, I want to touch on post-intervention imaging. Here's a patient you can see has evidence of a left-sided infarct. Here's caudate head, loss of the lentiform nucleus, and sort of blurring of the gray-white junction. Here you can see loss of the insular ribbon compared to the other side. So this patient goes on, this is a large vessel occlusion, goes on and has thrombectomy in the angio suite, and immediately after the angiogram, oftentimes they are, after they're in the angio suite, they'll get a CT scan, and you can see here's the occlusion that was managed at the time of the presentation, and there was revascularization. And then we see post-procedure, it looks like there is hemorrhage at first glance into the cortex and subarachnoid blood. But I want you to be aware of the fact that in most cases, you're looking at contrast staining. So as you might expect in the course of these procedures, multiple injections are made into the catheter in the involved territory where the physiology is not normal. And so there can be contrast actually leaks into the cortex and the territory of the infarct. And this is not hemorrhage, this is contrast staining, which can eventually lead to the appearance of subarachnoid hemorrhage, but this is again, contrast in the subarachnoid space, which is occasionally seen. So how can you tell the difference between contrast staining or hemorrhage? Well, to be honest with you, it's quite difficult. And I think the literature suggests that one of the things you can rely on the CT scan is if it looks like you have attenuation values in the order of the hundreds, 250, 300 Hounsfield units, you may actually be dealing with a hemorrhage, which seems counterintuitive, but in a sense, if there's that much contrast in the brain, it's not staining. This is probably contrast leaking out into the hemorrhage. But another technique that can be used is dual energy CT. And so basic X-ray physics, we know that from a photoelectric effect, the iodine in the contrast absorbs more low energy X-rays at around 33 keV than X-rays at other energies. So in a dual energy scanner, there are two X-ray tubes, and you can choose to set the X-ray tubes at different keV, a low keV and a high keV. And this will give you two images. Here we have one image obtained at a kVp of 80 and another at a kVp of 140. Now, when you see this, when the high attenuation looks about the same on both images, you should be suspicious that you're dealing with blood. How can you tell if it's contrast? What you should expect to see is it should be much more evident at the low KV image than the high KV image, because of that absorption of the X-ray is more at the lower KV energies. Another technique that's used is called virtual non-contrast. So some of the scanners allow you to reconstruct the images and process the dual energy to create this image that looks like there's no contrast. But this is the same data set as this one, only we've incorporated the low and high energy images into a virtual non-contrast. This area here, where we could say this could be hemorrhage or contrast staining, goes away, and that favors that this is contrast staining and not hemorrhage. And this was reported in the Journal of Neurology. So again, it does require you having access to a dual energy CT scanner, and that the patient gets scanned on a dual energy scanner after neurointervention. The important thing I want you to be aware of, though, which I think many of you already are, is in that first scan after the intervention, don't leap to calling all high attenuation hemorrhage, because that will alter the management. And I think in many cases, the best we can do is say this could be contrast or blood. And if you have any question, repeat the scan in about 3 days, 2 to 3 days, and the contrast tends to go away. The hemorrhage is usually preserved on the imaging.